So what we're going to cover is we're going to cover foot and ankle. Unfortunately, this is the last section, and this is probably from a biomechanical, MSK, PT standpoint, going to be the most difficult section. And this is why. This section of the body has a ton, and I'm talking a ton of moving parts. We are going to see parts moving on parts. We are going to see parts that make other parts move. We are going to see parts that move because of other parts. And then we're going to see parts that just kind of move just because they'd like to move. And that's just going to be how it is. So what I'm going to recommend is from now until the end of the semester, and I understand the end of the semester is only a couple weeks away, that you really dive into this section of material. OATIS textbook, the Gray's textbook, the notes that are online on Canvas, the functional lab packets, all of it. Because what you're going to see is that this material is going to be very, very dependent on all the other material that we cover. Because what you're going to see is that for motions, and you guys have kind of mentioned this in the past, pronation, supination, right? I've heard those words come out of some of you guys' mouths, and that's great. How many of you considered that pronation and supination does not only happen at the ankle? How many have considered that pronation and supination also happen at the foot? How many have considered that the tibia is going to move based on whether or not pronation or supination is happening? And then how many of you have recognized that tibia motion is then going to have ramifications at the knee, right? Because what is the unlocking and locking the screw home mechanism all about? Does not the tibia have some motion, some rotation to happen there? Okay, then moving up even farther, when my tibia moves, I could potentially have motion happening at my femur. If that motion happens at my femur, then I'm probably going to have motion at my hip. And if I have motion at my hip, then there's a good possibility that my lumbar spine will also be involved. Okay, so that's how I want you to start approaching this material. Because guaranteed there's going to be test questions that take it to that level. Okay, because at this point in time, everybody should be pretty well apprised what's happening at the lumbar spine, what's happening at the pelvis, what's happening at the femoral acetabular joint, what's happening at the patellofemoral joint and the tibial femoral joint, and then what's happening, as we're going to cover, in the foot and the ankle. Okay, so I want you guys to get really, really good at being able to build that chain. Okay, like I said, it's the old song we sung in kindergarten, you know, thigh bone's connected to the knee bone. It really is true. I want you guys to get very good at it, because as we study things in this course, we're going to study things from the static standpoint, and we're also going to study things from a little bit of the dynamic standpoint. But we're just going to kind of, no pun intended, dip our toe into the water of dynamics a little bit. I want you to get very good at it, because when you take exercise prescription over the summer, when you take exercise physiology over the summer, and when you take gait and biomechanics in the fall, these concepts are going to come back again and again and again. And when you guys see these concepts happen in the fall, it happens every fall. Someone comes into my office during their gait and biomechanics lab, and they're like, I totally forget the screw home mechanism of the knee. I need like a 30-second refresher. Don't be that person. Okay, so understand these concepts. So when it comes to the foot, there's going to be 3 different sections of the foot, or what we call 3 functional segments. The first section is going to be the rear foot. Now the rear foot is basically going to have two different bones, two different parts. My rear foot is going to be a little bit of my calcaneus, and it's also going to be my talus. And I'm going to put a little star next to this talus, because this talus, as we're going to see, really and truly is going to be the key to the ankle and key to the foot. That talus, as I've mentioned a couple times in the past, is not going to have a single muscle that attaches to it. There are 0 muscles that attach to the talus. However, that talus is going to dictate and it's going to help transition motion that's happening straight down or in line with gravity. Because remember, that foot has to take a 90-degree turn. So the talus is really key for offering that transition from a purely vertical concept to a perpendicular or horizontal concept. And that's exactly why we have that talus. The talus is going to be positioned and it's going to be shaped in a way that is going to literally perfectly transition that force. And we're going to get into the talus pretty in depth. The second section is going to be my midfoot. Now my midfoot is going to have 3 different bones or bone types that are going to be in that section. One is going to be my navicular. I'm also going to have a bone called the cuboid. And I'm also going to have 3 cuneiforms. I'm going to have a medial. I'm going to have a lateral. And then I'm going to have a middle. Now what we're going to see is that my rear foot motion is going to have an effect on my forefoot motion and my midfoot motion. Like I said, lots of moving parts here, right? How many bones are there in the foot? Like 27. Okay, so we got 27 things moving. My forefoot is going to have 2 basic sections. Now, each of these are going to have multiple pieces and multiple parts. I'm going to have my metatarsals, and then I'm going to have my tarsals. I'm sorry, I'm not going to have my tarsals. I'm going to have my phalanges. Or my digits. You're going to see metatarsal a lot of times in PT language is going to be abbreviated MTP. MTP is going to stand for metatarsal phalangeal joints. Okay, so this is my metatarsal phalangeal joints. So a metatarsal phalangeal joint says what it is and it is what it says, right? It is my joint between my metatarsals and my phalanges. As we are going to see, that is going to be a prime area that we need to be concerned about, because the eponym, the layman's term for the metatarsal phalangeal joints is, quote, the ball of the foot. Okay, and this is why I always kind of snicker when athletes are told to play on their toes or run on the balls of their feet. We actually don't have any balls in our feet, right? We do have metatarsal phalangeal joints though. So these are the three big sections. These are the three main sections. You're going to hear these terms over and over again, not only in the literature and the textbooks, but you're going to hear these clinically a lot. Any questions on rear foot, midfoot, forefoot? No, they're good. They're right at that point. All right, so the next thing I want to cover is going to be the next concept of varus and valgus. Because this is all going to build on each other when we start getting into supination and pronation. Okay, so rear foot varus. Okay, we've kind of talked about coxivarus or coxivera, genuvarus. Right now we're going to talk about rear foot varus. And what I want you to kind of imagine is, let's say we have the ground. Here's the ground. It's a nice green meadow, if you will. And what should happen, that's right. You see Rory McIlroy yesterday shoot like a 22 or something like that in the final round? Yeah. So what should happen? How do you think the calcaneus should be positioned relative to the ground if it is neutral? What's that? Perpendicular. Okay. So I'm going to draw a posterior view of the calcaneus. Believe it or not, it's going to look like a little box. Okay, and we're going to put a big C on it for calcaneus. So if my calcaneus is neutral, then it should sit on the ground in a very neutral position, right? Not tilted one way or the other. What we're going to see, and I'm going to give you some reference points here. Okay, so over here is going to be medial, over here is going to be lateral. What we're going to see is that if I have rear foot varus, okay, and let's think about what varus means. Okay, what is genuvarus? Okay, my proximal segment goes away from the midline. My distal segment comes in towards the midline. Right? That's what rear foot varus is. That's what genuvarus is. So rear foot varus essentially means that my lateral portion of my calcaneus is going to be on the ground, and the medial portion is going to be up in the air. So it's going to look like, and this is an exaggeration, but it's going to look like that. Okay? So lateral portion on the ground, medial portion up in the air. Now what you're already probably thinking is, okay, and my advice is as we're going through these motions, start doing them on yourself. Because what you're going to see is when I perform rear foot varus, what happens to the rest of my foot? Okay, try that. Okay, if I put the lateral portion of my heel on the ground and the medial portion is up, What happens to the, what do we call that motion? Inversion, right? Okay. What's happening to the rest of my foot? What portion of the rest of my foot is on the ground? The lateral side, the fifth metatarsal. First metatarsal is not on the ground, is it? No, it's up in the air. We're already seeing that my rear foot varus can have drastic consequences, drastic ramifications to the rest of my foot. Now, a rear foot valgus is going to be the opposite of that. So the medial portion is on the ground, and the lateral portion is in the air. And as soon as you guys get done drawing it, I want you guys to do that on yourselves and tell me what happens to the rest of your foot. Okay, so what is happening? My medial portion is on the ground, my lateral portion is up in the air for rear foot valgus. Okay, what happens to the rest of my foot? Maybe. Okay, so I have rear foot valgus. My first metatarsal phalangeal joint is on the ground, right? Yeah. My fifth metatarsal is up in the air. So let's think about this. Am I able to walk very efficiently with either a rear foot varus or a rear foot valgus? Why not?
Surface area.
Surface area. You can compensate, right? So how do I compensate? Okay. Mary Grace didn't say it very loud, but I'll repeat it. So what we're going to do is we're going to, you good back there, guys?
Sorry, I'm just trying to understand the drawings.
Okay. Okay.
Makes more sense to me what she drew.
So what we have is I need to walk. I need to get my foot on the ground, right? I need to get my foot on the ground. Is it beneficial for me to only have one portion of my foot on the ground, or is it going to be more beneficial to try to get as many points of contact as possible? Multiple points of contact, okay? Now this is the game, okay? This is the key. This will help you with gait, this will help your biomechanics, this will help you with gait observation in the clinic, making orthotics with patients, all of it, okay? I need 3 points of contact. I need the calcaneus, I need the fifth MTP joint, and I need the number 1 MTP joint. Just for stability. Okay, so every time I take a step, I need those 3 points of contact on the ground. And the reason I need those points of contact is that when I go through the gait cycle, and we're going to start covering a lot of gait, there's 3 basic phases of gait. There's the phase of force dispersion or force acceptance. So as I go through the gait cycle, I'm going to go through a period of force dispersion. Then I'm going to go through a transition phase, which is called mid-stance. And then I'm going to go through a period of force production. That's the gait cycle. Yep. So think about this. If I'm going through the gait cycle and I'm in that first period of force dispersion or force acceptance, do I want my foot to be rigid or do I want it to be flexible? Flexible, right? When I am trying to produce force, do I want my foot to be flexible or do I want it to be rigid? What's that? Rigid? Yeah.
It wouldn't depend.
Actually does not depend. So this is one of those times where it doesn't depend. Now, what will depend to make you feel better, right? So I can give everyone the it depends answer, is how that person gets there is variable. So here's what I want you to think about. And again, do this on your foot. If I have rear foot varus that's happening, what position did that place my foot and my ankle in? Inversion, okay? When I'm weight bearing in inversion, am I weight bearing on a flexible surface or a rigid surface? I'm weight bearing on the 5th metatarsal, which is pretty rigid, as opposed to the medial side, okay? Because the other thing we're going to get into are this concept of an arch. And we don't have one arch, we have 3 arches. So you may have to take your shoes off to do this. What I want you to do is I want you to go through and I want you to do rear foot varus and watch what happens to your arch, and then do rear foot valgus and watch what happens to your arch. What's that? Yeah. And why would your foot cramp?
Huh?
Why would your foot cramp? I know.
Oh. I was like,
It can. It can. It can. We're going to get into compensation. Yeah. No, you're good. You're good. Yeah. All right, so what do we think, guys? When I go into rear foot varus, what happens to my, and we're going to put this term on it, medial longitudinal arch? Does it increase? I got an increase. Why does it increase? No pressure on it. Gravity is taking my forefoot and it's pulling it down, therefore increasing an arch. Cool? Now, what happens when I perform rear foot valgus? What happens to my arch? It's going to decrease. So when I increase my arch, I'm going to increase the rigidity. I'm going to increase the stability of my foot. Okay? That's going to be very beneficial for when I produce force. If you want a really good example of this, and I'll ask you guys, who's taken the long walk on the beach before barefoot? And I'm not talking in all the sand that's packed down by the water. I'm talking the fluffy sand. Who's gotten really sore after that? Does it feel like it's a lot of work? Especially when it's hot? Okay, fair enough. Aside from the humidity and the heat and stuff. Let's say you're in Maine, and I know, not many people are going to Maine for the beach. Just taking the heat factor out of it, come on. But why is it more work to walk on that fluffy sand? It's not a hard surface, decreases stability, right? In biomechanics or physics terms, what decreases? Joint reaction force would be 1. What about the normal force? Right? Because now my normal force when I'm standing on the ground, and this surface here is going straight up through my body. What happens to the sand when I step on it? It kicks out to the side. So now my normal force is being dispersed, correct? So it's not going straight up through my body, it's being kicked out to the side. So in order for me to produce the same amount of force, to walk, I have to step harder. I have to produce more force. I need to create a stable surface, as stable of a surface as I can, to produce the most amount of force that I can. Does that make sense? And this is going to happen not only when we walk in the sand, and the sand is kind of an extreme example, but just when we walk down the hallway in this building, or out to your cars, or around your apartment, or whatever. So when I produce force, I need my foot, and I need my rear foot in a varus position. When I accept force, I need my rear foot in a valgus position. Okay? And the reason I need it in a valgus position is exactly what you guys just saw in yourselves. When I perform rear foot valgus, that creates a more flexible surface. A more flexible surface is going to be better at dispersing force. And this is going to become very important when you start diagnosing folks like long distance runners, soccer players, things of that nature, who are doing a lot of work on their feet.
Say it one more time. For
Yeah.
flexible, you want varus.
For flexible, you're going to want valgus.
Got it.
Yep, and we're going to get into that later. Like I said, we're going to build off this concept.
Thanks.
Oh, no worries.
You said to accept force
Accept force or disperse.
is back.
Valgus. Yep.
And then, did you say the other one was varus?
Varus is produce force.
So basically,
Yep.
what you're telling me is I come down, I want my foot shifted inward just a smidge. I eat a little bit of valgus.
A little bit of valgus, and that's exactly.
Step forward, that way it's going to redistribute a little more toward the outside. I'm going to have a little more varus as I.
That's exactly right.
So I literally am doing more work to run than other people. So that's exactly the opposite. My feet work. And I just showed them, you can tell on my shoes. I hit here, push off there.
There you go. So you know what? That's a great one. A great way.
Because comfortably, I'm like this.
Mhm.
I take my shoes off, my feet don't sit flat. Comfortable is this. Problem solved.
There you go. Perfect.
Run
Perfect.
every other person.
So that's exactly what we see. Strictly from the rear foot perspective, when I strike my heel on the ground, I'm first going to go through a period of rear foot valgus to make my foot flexible. Then as I enter mid stance, I'm going to start performing rear foot varus. And as I go into toe off, okay, that portion where I'm pushing off and my toes on the ground, I'm going to have rear foot varus. So literally what you see as the foot is entering the gait cycle and the weight-bearing position is you literally see this concept over and over again, where I'm going valgus, varus, valgus, varus, okay? In addition to dorsiflexion, plantar flexion. In addition to tibial rotation. In addition to femoral rotation. Yeah, now you guys see why you have 16 weeks of gait. There's a lot going on. This is the we're just scratching the surface here. So, like I said, my goal to create stability in my foot is to have my calcaneus, my first metatarsal head, and my fifth metatarsal head on the ground. So if I'm Dr. Justice, and Dr. Justice is a prime example for this, and Dr. Justice has a natural rear foot varus, how do you think I'm going to compensate to get my first metatarsal head on the ground? Not necessarily genu-valgus. Say it louder.
Leaning forward, like with this first page.
Forefoot valgus. I got you. It's okay. Calm down. Right? So if I have rear foot varus, my compensatory mechanism, okay, again, we're going to get into compensations again, just like compensated Trendelenburg gait and uncompensated Trendelenburg gait. I may see in my patient that I have rear foot varus and forefoot valgus. So that's what I want you guys to do next, is I want you to put your foot into rear foot varus and forefoot valgus and tell me what happens. Besides, it's going to hurt like a ton. Some people can't. You may have to so rear foot varus, forefoot valgus. So give it a shot. Rear foot varus, forefoot valgus. Who's having a tough time doing rear foot varus and forefoot valgus? It's a pain. It's a real pain. So why is it so painful? Why is it so difficult to perform rear foot varus, forefoot valgus? Could be. Let's think about it. What's preventing you from performing rear foot varus and forefoot valgus? What sorts of things are going to make it hard? What's that? Midfoot. Midfoot is a transition, gets in the way. What about the midfoot gets in the way? What's that midfoot made up of? Bunch of bones. Those bones are held together by what? Bunch of ligaments. Say it loud. Ligaments are restricting the motion. So now let's think about this. And I'm going to assume all of you guys are normal. Normal in terms of feet, right? Trust me when I said I'm abnormal. Okay. Throw that out there. You guys already figured it out. I'll just put it out there. What would I expect in terms of ligamentous stability if my patient has rear foot varus and forefoot valgus? Is it going to be hypomobile, normal, or hypermobile? probably hypermobile, right? Think about how tough it was for you to get down to that position, right? Did anyone have bone ache? Anyone like say, man, my foot's kind of cramping up because it doesn't feel like it should go there? So you are going to have to stretch the ligaments along with the tendon, along with the muscle, to get that forefoot, to get that first metatarsal phalangeal joint, that first metatarsal on the ground. Would that create a pathological, more flexible foot or less flexible foot? If I'm stretching out all the ligaments, does that increase flexibility or decrease flexibility? It increases flexibility. Now, you guys know this. When I increase flexibility, what do I sacrifice? Stability. Exactly. Exactly. Now, here's your patient. They come to the clinic. They're 38 years old. They put on a few pounds. They're looking to get back into running. They just watched a great video. You know, maybe David Goggins or someone got out there and motivated them. Truth be told, I love David Goggins. Yes, I follow him on Instagram like that's my guy. And they get out there and they're good and motivated, and they have Rearfoot Varus, Forefoot Valgus already happening. Would you expect them to would you expect them to be able to produce more force or less force when they are pushing off in the gait cycle? Probably less force. Which means what? If they want to achieve a stride, what are they going to have to do? Compensate, work harder, lots of different things. How many steps does the average person take when they're running a mile? What's that? About 1,500. Ballpark, about 1,500. So let's think about this. How many of you, working as techs, observers, had your patient do 1,500 bicep curls in a row? Anybody? Sam, you guys weren't doing that at Cape Fear? Oh, no? Okay. Maybe 1,400?
Yeah.
Okay, cool, very cool. But let's think about that. Okay, so I just did 1,500 repetitions of a pathological motion. What is that going to do to the plantar surface of my foot? What's it going to do to all the little muscles under there? They're going to get overworked pretty quick, aren't they? Because if I have to produce more force than normal with every single step, is there a possibility that I'm going to overtax that musculature? Very good possibility. All right, let's go ahead and let's take 5, get up and move around a little bit, and then we're going to move on to the next point. Yeah. Not always. So here's what you have to consider. So when we get the PT scroll, this nice gal, she had leg construction. One leg was shorter than the other. So that's how she compensated. Exactly. So what she did was her, if I remember right, her left leg was shorter than her right. And she was wearing shoes, you can tell because she had the inside of her shoe built up. When the shoes came off, okay, and because she needed to get her foot on the ground, and that was the only way she could have put her. And like after 5 minutes, she said, "I got her." She's like, "I get her." Because she had 3/4 of an inch or so, like, which is not nice to hear.
There was an athletic girl that had the cross sheeted 2 inches. Like in her finger, like it was actually 2 inches.
So I had a patient, gosh. Okay, here's today's weird fact. He's your age now. But I saw him years ago when he was a kid. He had a condition called proximal femoral shortening syndrome. His femur never grew past infancy. So talk about a labeling discrepancy. Yeah. On one side, normal.
Yeah.
The other side, I kid you not.
I've seen people like this on TikTok. They have a shoe that's
Yep,
like
he
this.
did. He had a sheet.
Yeah.
So then it doesn't grow.
They have to force it to grow.
Break the leg.
Over and over and over. So this 10-year-old had a brace. And every day, you had to turn it.
Yeah.
And then,
It's actually fun.
what's that?
It actually.
Oh, yeah.
So then, if it didn't grow, but did it grow in?
Yeah. So, on its own. On its own. What's that? We'll get into growth plates much more next year. So yeah, that's what he had to do. It was tragic. I've seen that kid since he was fifth grade. How is it? You'd be like 25.
I was like 10 years old.
You have a question? If you don't ask the question, you will never I'm sorry. Excuse me. Do it the old-fashioned way. All right, guys, let's get rolling again here. All right, so when it comes to the foot and the ankle a lot of times is referred to as a mortise joint. Okay, what a mortise joint means is something called a saddle joint. So what we have to understand is that the ankle is going to be made up traditionally of 3 bones. Okay, I'm going to have my tibia, I'm going to have my fibula, and then I'm going to also have my talus. Now, despite this being a really small space and a really small joint, there is a ton going on here. The first thing we have to understand, like I said, is that tibia is going to provide about 95% of the weight bearing. The other thing we have to understand is that depending on the person, and this is another one of those it depends things, the average person bears about 5% of their weight on the fibula. However, in a lot of cases, it's nothing. Okay, and I have seen patients come in, like I said, with fibular fractures, walking in like nothing ever happened. So just understand that the vast majority of my weight bearing is going to be done through my tibia. Now the joint itself, and we're going to space this in here, in yellow, this is going to go by a couple different names. Technically, this is the tibio-talar joint. Says what it is what it says, right? As we know, the vast majority of joints in the body are named based on the two bones that make up that joint. So you may see in the literature, in the textbook, and other stuff you read, a reference to the tibio-talar joint. When they reference that tibio-talar joint, that is exactly what they are referencing. The other term that often gets used, I'm going to put in quotes here, is something called the talo or talocrural joint. It is the exact same thing. So you will see this in documentation at the clinic. You will see this in several pieces of literature. They'll say, oh, well, the talocrural motion is this. What we need to understand is that at my tibio-talar joint or my talocrural joint, I'm going to have some different motions happening. Okay, we already kind of discussed all these, and you guys have already discussed these in tests and measures. At my tibio-talar joint, I'm going to see a different color here. Dorsiflexion, plantar flexion, inversion, and E-version. So those are going to be my main motions happening at the tibio-talar or talocrural joint. The next thing I need to consider, and this is going to have wide implications not only for this course and your MSK series and gait and biomechanics later on in this program, but also just clinical practice, is, and we've gone over this several times already, the concept of convex and concave, and those arthrokinematics. What we are going to see, and this is a little bit of an odd concept because it's not going to seem real intuitive, but the tibia is going to be considered to be my concave surface. And the talus is going to be the convex surface. Now, the reason that the talus is going to be the convex surface is if we look at a side view of the talus, and obviously this is a very rudimentary drawing. The most superior portion of my talus is going to come out to a big convex surface that's going to be called the Tailor dome. Okay? Obviously, we know what a dome is. There's plenty of domes that plenty of professional sports teams play in. It's just a big convex surface. So the most superior portion of the talus is going to come out to this Tailor dome. So what I need to start thinking about is during each of these motions, dorsiflexion, plantar flexion, inversion, E-version, number one is what's moving on what, right? An open and closed chain is exactly right, right? So am I moving in the open chain? Or am I moving in the closed chain? All right, so let's review real fast. Open chain means what? Right. My distal attachment not really touching anything. Closed chain, my distal attachment is touching something. So how would I, again, here's a T-ball question. How would I perform open chain dorsiflexion? Right? Open chain dorsiflexion, easy as pie. How would I perform closed chain dorsiflexion? Okay, bring my knees forward. Now, that was who said bring my knees forward? Interesting concept. Are you able to perform closed chain dorsiflexion without bringing your knees forward? Show me. Michael Jackson? The lean? Okay. So if I'm catching this right, okay, I can perform. I'm performing closed chain dorsiflexion without bending my knees. What? Can you say that louder, please? They don't have to be, but they can be, right? Because that's what you guys see in the clinic a lot, right? Patients get on a slant board, right? So if my patient's on a slant board, which I'll tell you, every clinic has a ready-made slant board, it's called a wall, right? Just put their foot up on the wall. Sorry. No, I manage clinics, I'm a cheapskate. Why spend the $35 when you don't have to? That's kind of how I look at it. Exactly. So I can perform closed chain dorsiflexion with or without knee motion, right? And that's going to be another huge concept. Because as I am going through the gait cycle, well, the next thing we're going to see is that my position of my knee is going to influence the position of my ankle. Okay? Now, you've already mentioned bring the knee forward. In PT terms, what's that called? Am I flexing my knee or extending my knee? Flexing my knee. Okay? Burn this one into the prefrontal cortex. Knee flexion will create dorsiflexion. Knee extension will create plantar flexion. And that's an important one. That is a super, super important one to remember because, and let me ask you guys this. Who is familiar with an AFO? What does AFO stand for? Ankle foot orthoses. Why would a patient need ankle foot orthoses? What's that? Drop foot would be a really good one. Or maybe their foot's stuck in plantar flexion. So if I'm not wearing my AFO and I try to contact the ground, what's going to happen? Am I going to contact with my heel or contact with my toes and forefoot? Toes and forefoot. Now, we already talked about, in order to get that 3 points of stability, I got to do something. I got to get my calcaneus on the ground, but it's not going. So here's what the patient does. They hyperextend their knee to a pathological amount, because I can get my knee back there and get my calcaneus on the ground. And I have seen this happen with patients. Pathological hyperextension is a condition, you may have read this in the OATIS textbook, called genu recurvatum. And that's what genu recurvatum is pathologically hyperextension of the knee. And I've had patients where I've measured it, I kid you not, they're in 35 degrees of hyperextension. And that's how they stand. And why do they stand with 35 degrees of hyperextension at their knee? Because they are unable to stand with the appropriate amount of dorsiflexion and have that 3 points of contact happen. So in order for them to get the 3 points of contact between the calcaneus, first metatarsal head, fifth metatarsal head, they compensate by extending their knee to a pathological amount. If you look at that patient at the surface, what do you think? Dude, your knee's jacked up, right? Man, we need to do something to your knee. In reality, where's the actual source of the problem? At their ankle, right? So what do I need to do as an intervention as a physical therapist? Ultrasound, stim, right? Diathermy, microcurrent. Do what else? Ionto. What's that? Yeah, cold. Actually, yes, yes. Because think about this. Think about this. Okay. So I need to improve dorsiflexion, right? That's what I need to do. If my patient is in negative 35 degrees of dorsiflexion, and I need to get them to 0, is that going to feel very good? No. So I may actually have to do some cold spray, and I've done it. So believe it or not, what I have done, obviously check skin integrity, check all that stuff. I've lathered them up with biofreeze. Got that idea from my dentist, right? Who's got a cavity filled, right? What's the first thing they do? They take a little swab of oral gel, stick it in there, so be back in 5 minutes. Numb you up, and then take a needle like this long, and shove it through your jaw. Yeah, exactly. Look up at the light, right? But that's where I got the idea. I was like, wait a minute, that works. Because what am I trying to do? I'm trying to numb the surface. I'm trying to distract the patient away from the actual source of the pain. So believe it or not, I used to do it all the time. Take a little bit of biofreeze, rub it on the back of their leg on the gastrocs. All right, see you in 5 minutes. Come back in 5 minutes. They're getting that cold, tingly, whatever sensation. All right, let's get in there and stretch. We used to do it a lot. But if I would not have understood the relationship between the knee and the ankle, I would have gone in and intervened on the knee and gotten nowhere. The problem was at the ankle. Okay, so you have to understand how this happens. So again, knee flexion is going to create dorsiflexion in a weight-bearing environment. knee extension is going to create plantar flexion in a weight-bearing environment. Now, what about inversion and E-version? Will my knee position potentially influence my foot and ankle position? What's that? Screw heel mechanism can have a little bit to do with it, absolutely. Let's dial it back one step though, no pun intended. Genu varus, genu valgus, right? What's genu varus again? Bow-legged, right? Genu valgus is what we like to call knock knee. So if I have genu varus and I need to get those 3 points of contact on the ground at my foot, what's my foot going to do? Is it going to invert or is it going to evert? Probably evert, okay? So what I may see is that my patient with genu varus has maybe more pronation, right? We're going to get into pronation here in a little bit, but they're going to have more eversion because I need to compensate to get those 3 points of contact on the ground. So really and truly, as you guys are approaching these problems, and like I said, I think you're getting a good appreciation. Things are going to get real complex real fast. Always go back to the basic rules. When I'm standing, I need 3 points of contact. Okay? Calcaneus, first metatarsal head, fifth metatarsal head. How I get that is all going to depend on what everything else is doing. Everything from knee position to potentially hip position to potentially leg length discrepancies, all sorts of fun stuff, right? You guys are going to see a little bit of everything in your careers, I promise you that. But it all comes back to that basic rule. I need to get 3 points of contact. Calcaneus, first met head, fifth met head. Okay, any questions on that? Okay. So like we talked about, joints of the rear foot are going to be the calcaneus and the talus. What I'm going to need to understand is, and I'm going to draw this like the person standing on the ground. My calcaneus, essentially, like I said, is going to be this kind of large boxy bone here. And my talus is going to kind of sit on top. But it's not going to sit directly on top of the calcaneus. So I'm going to have some stuff that sticks out. I'll give you guys a couple points of reference. Posterior, anterior. And then this line is going to represent center of rotation, or as we like to call it, the axis. So when I'm looking at these bones from the lateral perspective, what I'm going to see is that the calcaneus is going to have more of a posterior presence, if you will, behind the center of rotation or the axis than the talus is. Now what we're going to see is that when my calcaneus moves, and at this point what we're talking about is this joint down here. This joint right here, I'll put in a different color here. So this little joint between the talus and the calcaneus is going to be called the subtalar joint. Now you're going to see a ton of literature next year in MSK, tons of literature in biomechanics and gait, and you may have already heard this term used copiously in the clinic. But what's the subtalar motion? Or, well, let me ask you guys, who has seen a physical therapist fit somebody for orthotics or cast somebody for orthotics? Anybody? You have? Did that therapist try to get subtalar neutral? Did they talk about getting subtalar neutral? What is subtalar neutral? What does that mean? Says what it is what it says. It's where it's a neutral position of the subtalar joint. Now, here's the fun fact of the day. For those of you who watched that therapist get subtalar neutral, how did they know they were getting subtalar neutral? They didn't. Because the psychometrics on how therapists achieve subtalar neutral is absolutely all over the place. And I can remember in the clinic one time, therapist who, she'd been out 15 years more than me, and she's sitting there, oh, you got to work on getting subtalar neutral. She thought she had it. I thought I had it. Who knows? Yeah. So essentially what subtalar neutral is, and you're going to hear this a lot when casting for orthotics, and there's still a lot of PTs out there that cast for orthotics. Essentially what they're trying to do is they're trying to place the talus so that the talus does not have any inversion or eversion. So it is in a essentially neutral position. And what the theory is that if you place the subtalar joint in the neutral position, the foot is going to naturally fall into either rearfoot valgus or rearfoot varus, forefoot valgus or forefoot varus, whatever it is. And then you cast for the orthotic in that position. Because for those of you who wear like shoe inserts or orthotics, whatever, why does someone wear orthotics? What am I trying to do with orthotics? Say it louder.
Support and stability.
Support and stability. Okay, yeah. So essentially, it all goes back to those 3 points of contact. So what I'm trying to do is I'm trying to provide an additional support and stability system so I can achieve those 3 points of contact in the easier fashion. So essentially what I'm trying to do is I'm attempting to bring the ground up to the foot. Does that make sense? So if I have a very flexible foot, and I have, quote, fallen arches, right? That's a term like people like to use. I'm going to place that person in subtalar neutral. Then I cast based on where their foot is in that neutral position. That cast is then taken to a lab. And essentially what they do is they put the cast on a plate and they measure how much distance at a bunch of different points they need to build up an insert or orthotic. So essentially what they're trying to do is build this orthotic up and build the ground up to the foot. Now, let me ask you guys a question. This is not terribly off topic, but a little off topic. What's the problem with that casting system? It's expensive. Okay, that's number one. What's another problem? Say your answer, then your answer. Going to change over time, possibly.
It's going to keep them in the same spot in the long run.
Okay, it doesn't allow for any adaptability. Okay, Gary, you said you saw a therapist do this. Okay, makes a mess. Yes, it is terribly. It's terrible. Yeah, it's 10 times worse than movie Ghost, right? And I know you guys have probably never seen Ghost, but how is that patient positioned? They were prone. Right. So when I'm prone, what's not on the ground? Your foot. Right? So when my foot's not on the ground, what do we call that? Non-weight bearing. When I'm standing, bonus question, am I weight bearing? Yes. So what's the problem with that system? Exactly. Exactly, right? I'm testing in an environment that's not functional. And this is why orthotics sometimes have a very high failure rate. Because as we've already talked about, when I bear weight, lots of moving parts, lots of things are happening, right? So I would highly caution casting a patient in a non-weight bearing position, simply because things are going to change, right? And to your point, people are going to age, okay? And I've seen this happen over and over again. Had a patient, got orthotics when she was 12. Well, what happens typically when you're about 12 years old? Adolescence, puberty, and a big old growth spurt. So here's the problem. At that point in time, orthotics ran about $250. Well, little Susie grew like 4 inches in her like 8 shoe sizes or something. So were the orthotics effective at that point in time? Heck no. So be very, very, very careful with this. Okay, so what we're going to see is that my calcaneus is going to have a very direct effect what happens at my talus. Now, again, remember, there are no muscles that attach to the talus. So why is that important, besides not having to remember those attachments for things like lab exams? Say it louder, David. Right, nothing's moving the talus actively. So then my talus is going to move exclusively through passive means. The talus is just going along for the ride, and that's all it's doing. So my talus is going to react to whatever happens to it, whatever's happening in this environment. And what we're going to see is that that talus is just going to slide all over the place. So remember that, because as we move into a lot of these complex motions like supination and pronation, understand that my talus is simply going to react to what my calcaneus is doing. Let me give you an example, okay? Like I said, the talus is going to sit a little anterior, and if we actually look at the exact angle, it sits at about like a 42-degree angle or something. So it's already on a little bit of a slope. So here's what I want you to think about, okay? If I am performing plantar flexion, number one, what muscles are going to help me perform plantar flexion? Gastrocnemius, triceps surae, soleus, all that great stuff, right? Where does the Achilles tendon or calcaneal tendon attach? What part of the calcaneus? The posterior part, back here. What's that? It hinges. So then, here's what's going to happen. Okay? Hey, person, I want to perform plantar flexion. Well, there's a distance there, isn't there? Little movement arm. Oh my gosh, biomechanic's coming back. I love it. So as my gastroc, as my soleus contract, it's going to pull that calcaneus two different directions. One direction is going to be superior. Cool. What's the other direction going to be? Posterior. So my calcaneus is getting pulled superior, posterior. How is my talus going to react to that? Anterior, inferior. Right? So as my calcaneus goes superior, posterior, my talus is going to go anterior, inferior. And that's going to be a really big, important concept when we start getting into these complex motions, like I said, of plantar flexion, dorsiflexion, especially supination, pronation. So let's think about this. Okay, plantar flexion, my calcaneus is moving superior, posterior. What about dorsiflexion? Dorsiflexion happens too. How would my calcaneus move for dorsiflexion? Yeah, anterior, inferior. So then how's my talus going to move? Posterior, superior. Okay? Literally, what I want you guys to do, here's my calcaneus, here's my talus, two fists right on top of one another. When one moves, the other one goes the opposite way. When one moves, the other one goes the opposite way. That's literally all they do. Okay? Calcaneus and the talus just react off one another. Okay, Newton's third law. For every action, there's an equal and opposite reaction. That's the relationship I want you guys to understand between the calcaneus and the talus. We're going to see this over and over and over again. Okay, any questions about supination, pronation? Okay. We're going to cover one more thing, and then we're going to cut it for the day, okay? Everybody good with this awful picture? Okay. So now what we're going to do is we're going to look at a posterior aspect, or posterior view of calcaneus and talus. All right, so, hey, wait a minute. Okay, there's my ground again. Okay, so for simplicity's sake, we're going to make the talus look like, in my mind, a slice of sandwich bread, and we're going to make the calcaneus look like a box that got beat up a little too badly. Like, these are usually how the boxes arrive at my porch from, delivery places. Just, this is a little off.
Sore spot there.
Yeah. Let's call it a recent sore spot. Like, Boy, that was one thing I did
On
not.
the side of the box, too.
No, it's not fragile. It's fragile. It's Italian. So here's the next two concepts I want to cover. Okay, points of reference. This over here is going to be medial. This over here is going to be lateral. So inversion, E-version. When I am performing open chain inversion, what direction does my calcaneus travel? Medial or lateral? Does it go inside or outside? Performing inversion goes medial, right? So my calcaneus is going to travel medial. Like we said, talus is going to react to whatever calcaneus does. I'm going to expect to see my talus go what direction? Lateral. So inversion, I'm going to see medial calcaneal displacement, lateral talar displacement. And we're not going to see much, because remember, what's also encasing that talus? What's on either side of that talus? All right, this big old mortise joint here, right? So this talus doesn't have a whole bunch of space to move. But understand that it's going to be a lot of relative motion. And there's actually going to be a test that you guys are going to learn next year in MSK called the Tailor tilt test. And that's exactly what the Tailor tilt test does. Is you're going to take that talus and you're going to tilt it back and forth to measure how stable that talus actually is in that system. But again, have to understand how the mechanics work in order to understand how the test is going to work. Okay, any questions on that? All right, let's go ahead, let's cut it here for the day, and we'll see everybody in lab.